My screen is visible now, ma'am?
Yes, screen is visible.
Okay. Shall we start? We're very happy to have you all back in our next class of the Scale Advanced ART Masterclass series. Today we are going to have the part 2 of the genetics topic that was very interesting, and it went on with a very nice discussion. So we're having the part 2 of that. And we're very grateful for Fiona for accepting and giving another lecture for us. Before I can introduce the speaker for the day, I'd just like to reinforce that we're introducing 2 exclusive certificate courses. One is Genetics and Infertility, which is a 12 weeks online course in association scale, that is Sri Chakra Academy of Learning and Education, along with TAPISAR. There is a 12 weeks online course with classes once a week. It's going to be during the weekdays only, so that it is easy for everybody to attend. And the other course is in reproductive immunology. This is an 8 weeks course where with one class every week. So the speakers are going to be experts, including Fiona for genetics, so that everybody is learns really well and is thorough in the subject by the end of this certificate course. So we encourage all of you to participate, and we are getting very good feedback already, and many people are showing interest to join. So we assure you that it is going to be a very useful course for your everyday, day-to-day practice. With that, I'd like to invite the speaker for the day, Dr. Fiona Olivita de Souza, who's very popular, and she's the head of scientific operations at Anderson Diagnostic Services. She's a PhD in clinical embryology from Manipal, and she has a certified program in genetic testing and sequencing technologies from Harvard Medical School. And she takes care of the operations all over India, Sri Lanka, and Nepal. And she is just one phone call away for any doubt or clarifications. And she has over 13 publications in high impact factor journals. And she's an excellent speaker. So thank you for being with us today, Fiona. Over to you.
Thank you, Dr. Sindhuja, for that warm invitation. And thank you, Vasundara ma'am, for the invite to be part of this program. It's really a joy to be here.
It's indeed a great pleasure to have you again. So today the time is all yours. We are not going to stop you. You please, we are ready and motivated to listen to you again.
Sure, ma'am. Thank you so much. So today we are going to be discussing on the second part of our from genes to generation topic. So today the focus is going to be on exclusively genetic variants that are responsible for infertility and responsible for IVF failure. So just to rehearse a little bit that we have already discussed in my previous session, basically the human genome comprises of 23 pairs of chromosomes, 22 autosomes, and 1 pair of sex chromosomes. All these chromosomes combined together form our entire human genome. Parts of these chromosomes are labeled as genes, and genes have introns and exons. Exons are the active portion of these genes which are involved in instructions to form and develop and function the body, and introns are regulatory subunits. So we have a total of 25,000 genes as part of our genome, which are responsible for our day-to-day body formation and function. And whenever there are any variations on the standard genetic code, we can get genetic diseases, which can have a cascade of implications, including the ability to conceive and sustain a pregnancy. So we are going to go through all these variants which are responsible for these fluctuations. So if you look at genetic factors, we know that genetic factors are equal while compared to the causes of infertility. They can be both male and female in origin. But among all these factors, 15 to 20% of infertility is caused by genetic conditions. So these genetic conditions could range anywhere from chromosome changes to subchromosome changes, and they can trigger compromised quality of gametes. They can cause impaired embryonic development. They can create challenges that impede implantation, and they can also cause miscarriages and predispose to miscarriages as well. So if we look at the level of testing, so genetic testing do not cover a one-size-fits-all situation. We have different genetic tests for different positions of the genome that we are looking for. We have chromosomal abnormalities, which is looked at by a karyotyping test. It is a standard test, and we as geneticists always insist that this is the first genetic test to be done, should not be skipped in any condition while going ahead for advanced genetic screening. So this includes chromosomal number changes and structural changes. We have subchromosomal that could be small deletions and duplications. When the world of infertility, the most famous deletion is Y chromosome microdeletion, which causes azoospermia. And then you have single gene mutations, which are responsible for multiple phenotypes, ranging from sperm production to oocyte development to embryo development to embryo implantation. So just to rehearse about mutation versus polymorphisms, because today I'm going to discuss extensively on these two factors. First is a mutation. It is a permanent change in the genetic sequence. It is inherited or can be acquired for the very first time, called de novo mutations. These are rare occurrences, present in less than 1% of the population, and often associated with diseases. So if there is a mutation, it definitely causes a syndrome or a condition. And if it's present in fertility associated genes, you will face infertility. Whereas polymorphisms are common changes and variations on the DNA sequence, and these changes could sometimes be benign and sometimes may predispose us to particular diseases. Polymorphisms are usually population specific and can also predispose to infertility as well. Now, coming to genetic causes of male fertility. The first and foremost is chromosomal causes. Now, chromosomal anomalies, as I said, can be seen frequently in the infertile population. They have been reported to be present in 15 to 20% of men with azoospermia and 15% of men with oligozoospermia. So if you look at the most common condition we face, it's of course Klinefelter syndrome, where you have 47 total chromosomes because it's a male karyotype with an extra X chromosome. Now, this usually results in men with small testes, tall stature, gynecomastia, hypogonadotropic hypogonadism is also seen, and it also disturbs spermatogenesis. So there is a possibility of these patients having azoospermia, which is seen in 10 to 12% of these patients. We can always, there is a 40 to 50% possibility of retrieving sperm on microTSA. And usually, because of the process of meiosis, patients with Klinefelter syndrome can make chromosomally normal sperm, though the predisposition to abnormality is slightly present. So ideally for patients with Klinefelters whom we are opting for IVF, PGTA is suggested to be included. The excessive X chromosome, that is poly X aneuploidies, are very, very rare, and they usually cause severe testicular atrophy, and the prognosis is poor, so they'll be azoospermic. But we have not come across any such cases because of the extreme rare situation. You also have Jacob syndrome, which is 47XYY. Here you have an extra Y chromosome, and then its incidence is 1 in 1,000 men. These men have tall stature, normal virilization, have some learning difficulties, ADHD, autism-like spectrum conditions, and these patients also have a higher predisposition to aneuploid sperm. And in case we are able to retrieve sperm, they have been 20 to 40% cases with the oligozoospermia. We include PGTA while offering them IVF. Then, of course, there is the mosaic karyotype, where you have a combination of 46XY and 46X. And this can cause mixed gonadal dysgenesis with the ambiguous genitalia and hypospadias. These are usually infertile individuals. Next, coming to the most important factor, that is sperm DNA fragmentation. This is also a genetic condition, so I have included this. And this is very close to my heart because I worked a lot with this phenomena. And DNA alterations in sperm can result mainly during spermatogenesis, because once the sperm is packed into its beautiful toroid structure where it is highly proteinated, it is pretty stable. So, but during spermatogenesis in the nucleosome model version of the DNA, it is very labile. So you have single strand breaks and double strand breaks that can be acquired due to several factors during spermatogenesis. And we broadly categorize DNA fragmentation into low and high. So usually the cutoff is around 15% to 20%. It is highly inconsistent between studies. So usually if the DNA fragmentation is on the lower side, let's say 12 to 15% or so, this does not really cause any effect on the IVF outcome. It does not affect embryonic development or the development of embryos. But if you look at DNA fragmentation, which is on the higher side, above 25%, it has been shown to consistently impact the developmental ability of embryos. And there was this beautiful paper recently published in 2024, which showed they compared two main groups. One was a no DNA fragmentation group. This was DNA fragmentation below 15%. Then there was DNA fragmentation between 15 to 30, and there was DNA fragmentation group above 30% with no female factor infertility. So they clearly showed that as the percentage of DNA fragmentation increased, the possibility or the probability of miscarriages also significantly increased. So between the first two groups, the 15% and the 15 to 30%, not much significant difference. But above 30%, there was significant difference in the miscarriage rate. Interestingly, in this paper, they did not find any difference in the fertilization ability. So this is a well-established fact that increased levels of DNA fragmentation do not strongly impact the fertilization ability of sperm. Whether you do in conventional IVF or IUI or ICSI, it's not going to impact the fertilization ability. But definitely it is going to impact the ability of the embryo to grow. Now, the oocytes usually have a limited amount of DNA repair capacity. So if it's a low fragmentation index sperm, to some extent, the oocyte can replicate, resolve the challenges and repair it. But DNA double-strand breaks are also been implicated in segmental aneuploidies that we get in PGTA results. So these are important findings. So how does sperm DNA fragmentation impact embryonic development? No impact on fertilization ability, but it can cause aberrant DNA repair would be deficient from the oocyte also. But it definitely significantly will reduce your cleavage rate. It can increase the risk of molodiris. It can also cause poor blastulation. But in certain cases, it can still give you good blastocysts, which go on to undergo implantation failure or even first trimester miscarriages. So you have significant reduction in birth weight also that was reported in the study that I just referenced. Next is Y chromosome microdeletion. So it is the go-to test for azoospermia. So when you have azoospermia, first we need to diagnose if it is obstructive or non-obstructive azoospermia. In non-obstructive azoospermia, the primary test is karyotyping. The secondary test is Y chromosome microdeletion. So in the Y chromosome, you have two main regions. One is the SRY region, which basically encloses all male characteristics inside it. And then you have the AZF, that is the azoospermia factor gene, which is divided into three main regions, AZF, A, B, and C. So based on the region that we visualize, you will be able to have an idea if this patient is a good candidate for TISA, and therefore the test is indicated before we go to offer TISA to such patients. Now, AZF-A deletion is pretty strong. It usually causes Sertoli cell-only syndrome, and usually there will be no sperm in the testis, so there is no possibility of getting any sperm during TISA. AZF-B also causes maturation arrest, and therefore in such cases also TISA is not indicated. AZF-C is a milder version of the deletion, and usually you have patchy spermatogenesis. You also have these patients with oligozoospermia. So we see a progressive decline in the semen profile in such patients. So they would have been oligozoospermia 5 years ago, and now they're azospermic. That is possible. So usually if individuals are coming to us early, we can offer them fertility preservation options, at least when they are oligozoospermic itself. So there's a 50 to 70% possibility of sperm retrieval. And AZF-D is a small distal deletion. So this has the best prognosis. The possibility of getting sperm increases. Now, as a point of genetic counseling for patients who are positive for Y chromosome microdeletions, we need to keep in mind that these are going to be inherited to all male offsprings, and all male offsprings are going to face the same phenotype, azospermia or progressive oligozoospermia to azospermia phenotype, and therefore early fertility preservation measures can be employed. However, interventions like PGTM for Y chromosome microdeletions to prevent the transmission of this condition are not recommended, mainly because the phenotype is restricted to only azospermia, does not cause any other developmental issues and any kind of neurodevelopmental challenges, and therefore the risk for an abnormal offspring is extremely low and equivalent to the general population. So the only challenge will be azospermia, which can be corrected with the same option that we are offering this patient. Therefore, we do not offer it, even if it means that the patient can request us to select only female babies. But because of PCP&LT restrictions and it's a gray zone, we prefer not to offer such interventions. If the patients insist for such interventions, we usually ask them to go get a court order and go through the legal route so that the center and the genetics lab are well within the legal rights to offer such interventions. Next is Obstructive azoospermia caused by congenital absence of vas difference. This is a developmental defect where the vas difference is not formed, but testicular spermatogenesis remains unaffected. So in these cases, usually the patient will have normal testicular size, normal FSH, low ejaculate volume, mainly because of the absent vas difference. The indicated test here is CFTR full gene sequencing with one intron 8 poly-T tract test. Basically, this increases a certain copy number on the CFTR gene. If it is negative, we need not worry. You can go for a follow-up test on another gene called ADGR2 X-linked, but it's not mandatory. But if the patient is positive for CFTR, ideally the female partner should be tested. So usually what happens is the patients who have CBAVD usually have one strong mutation and one mild mutation as a combination. So in such cases, if the wife also has a strong mutation of heterozygous state for CFTR, this can combine together and cause cystic fibrosis in their children. And for these cases, we can offer PGTM. So CFTR mutation is indicated in all CBAVD cases. If the patient is positive, go ahead with the female testing. If the female is positive, go for pre-PGT workup followed by PGTM. If she's negative, go ahead with the IVF cycle without any intervention. So this is the flow chart for evaluation of azoospermia. First, categorize if it is obstructive or non-obstructive. And also severe oligospermia patients are included in the evaluation. You can also choose to include teratospermia patients. First test to do in non-obstructive is karyotyping. If it is abnormal, we have our answer. If it is normal, go for YCMD. If you have no microdeletion, you can, sorry, one second. So no microdeletion, you can choose genetic panels which will find a genetic cause of azoospermia. Now, in case there is azoospermia and the patient is willing for donor sperm, we need not do any of these investigations. You only need to do these investigations when the patient is insistent on a cell cycle. Of course, obstructive azoospermia is not an indication for donor sperm cycles. You can go through the CBAVD, CFTR testing, followed by, if the mutation is present, test the female partner and go about it. Now, there are certain single gene defects also that are responsible for male infertility, and only by looking at the phenotype will we be able to understand that this patient is somebody who needs genetic testing. One of the classic conditions is Noonan syndrome. So in Noonan syndrome, basically the phenotype that we see is cryptorchidism, present in almost 80% of males with Noonan syndrome. This is a dominant condition. It also has a recessive version as well, but the dominant condition can cause male infertility. It can also cause gonadal dysgenesis, so you have hypogonadism as well. In the hormone profile, we will be able to look at elevated FSH, low inhibin B, and normal to low testosterone levels. And you can have reduced germ cells and fibrosis. Now, the importance is Noonan syndrome has several other phenotypes also, which includes intellectual developmental issues and can have embryonic lethality. And if this variant is present in the dominant stage, it can inherit it to their next generation at 50% risk. So for these conditions, PGTM can be offered as to avoid the inheritance risk in case the patient is insistent on cell cycles. So what is the possibility of us retrieving sperm in Noonan syndrome? So if there is Noonan syndrome without cryptorchidism, 60 to 70%. If the cryptorchidism has been corrected early, the probability of us getting sperm is anywhere between 10 to 40%. But if it is not corrected and we already are facing hypergonadotropic hypogonadism, we have less than 10% possibility of retrieving sperm. Another condition is androgen insensitivity syndrome. This is an X-linked condition, so it's going to affect only males. And individuals may have varying degrees of insensitivity to androgen, and basically it's divided into 3 types. You have complete AIS, partial AIS, and mild AIS. So depending on the variant and its manifestation, you can classify the patients. And here you will have elevated LH, normal to high testosterone levels, and low to normal FSH. The molecular testing for this is AR gene. So this is androgen receptor gene. It is available in a male infertility panel, or it can be availed as a single gene testing alone. And it can also be found in patients who have disorders of sexual development. So they could be phenotype as 46XY, but female, presenting as a female phenotype with absent uterus and ovaries. One of the other conditions that are associated with hypogonadotropic hypogonadism is Kalaman syndrome. This is a condition with which is characterized by delayed or absent puberty. Several genes are associated. It basically has impaired function of GnRH, that is the gonadotropin releasing hormone, which results in insufficient levels of FSH and LH. And usually a panel-based testing is important because genes associated with Kalaman syndrome have autosomal recessive, autosomal dominant, and X-linked variants. So in case, if it's a male or a female with Kalaman syndrome, it can happen in both genders. And usually it is important to run the test to make sure that the inheritance risk can be avoided by genetic interventions. Primary ciliary dyskinesia is a condition where you have complete lack of motility in sperm. The classic example is cartilaginous syndrome. Basically, it's a genetic disorder where the cilia dysfunction in the body. It is an autosomal recessive condition. That means 2 alleles are required to be damaged for the disease to manifest itself. And it can also present as asthenozoospermia. Usually, it is also associated with recurrent respiratory infections as well as situs inversus. That means the organs are on the opposite side of the body. Like the heart is usually on the left, it can be on the right in such cases. So they can also have bronchiectasis, and this is a pathogenic condition. And usually, if you have 2 carrier parents, also it can affect a child. So here also interventions are allowed. Now, overall overview is that as the quality of the sperm or the semen profile reduces, the possibility of genetic conditions involved also increases. So if you look at azoospermia to oligozoospermia, you have about 70 to 80 genes involved in predisposing to these conditions. And then when you have astheno and teratoma also, you still have about 45 genes included. You also have genes associated with fertilization failure. So while employing these panels, the diagnostic yield is reported to be anywhere between 10 to 19%, depending on the semen profile and the phenotype of the individual. So this was a case I just put in for example. This was a couple with primary infertility. We went in for couple carrier screening because they were a 2nd degree consanguous couple. But the patient only had asthenoteratozoospermia. The initial plan was to do ICSI, but they stressed because they were consanguous. So we did a couple carrier screening with whole exome sequencing. Here we found a gene FSIP2, which was associated with spermatogenic failure. This is an autosomal recessive gene, homozygous. So this basically causes a condition called MMAF, multiple morphological abnormalities of sperm flagella. So why is this important? You would tell me, generally any IVF specialist would tell me, if I'm able to get one structurally normal function sperm, I'm able to fertilize one egg at least. Why we do this is, ideally, when we find abnormal semen parameters, the instinct is to suggest lifestyle modifications, which is the guideline-oriented way to go, and suggest certain medications or exercise and antioxidants to improve the semen profile. But when you have a genetic cause listed, then we are losing that 3-4 months of fertility. Because if there is a genetic condition, these kind of interventions are not going to improve the phenotype of the individual. Therefore, this testing becomes important. The inheritability risk, of course, is present only if the wife is a carrier. So in this case, the wife was not a carrier. I have not included her report here. So there was no inheritance risk to the individual. So based on this results, we directly went in for ICSI for this patient. So what is the possibility and findings that we get with mutations associated with MMAF? The possibility of us getting sperm are about 90%, so it's high. We can use testicular sperm, but they will be non-motile, but they will be viable for ICSI. There is no issues with fertilization. The reported fertilization rate is around 60 to 70%. There are very few studies because the variants are rare. And around 30 to 40% pregnancies have been reported in the few number of studies that have done it. So it does not really impact embryonic development. So based on these facts, we decide, okay, this is not a detrimental variant for us to worry about. We can rest assure the patient, let's do ICSI, and we can go about having a healthy child. Another important variant is Catspur. I actually met the scientist in Aspire this year, so it was a very interesting conversation we had with him. So this is basically a calcium channel on the sperm. It is there are several Catspur genes. Catspur 1 to 4, you have gamma, beta, epsilon, etc. And they basically assist the sperm in achieving hyperactivated motility. Now, hyperactivated motility is achieved in the female genital tract on exposure to progesterone. And in the absence of this gene, if the gene is rendered non-functional, the sperm will not be able to reach the oocyte. So in patients who have this CAT-SPR variants, they are not able to achieve pregnancy. So you will have these patients coming to you with primary infertility. So natural conception is not possible. And what happens with the semen profile is we can get to see oligozoospermia or normozoospermia as well. They can be actinozoospermic as well. But in most cases, you might have normal sperm profile as well. Now, it is important because CAT-SPR mutation is autosomal recessive. It has 25% recurrence risk. And the reported study, I would like to grab your attention here, the pedigree, if you can see. This is an important deletion on the CAT-SPR gene. So these were two parents who were non-consanguous, who were carriers of this deletion. So they did not have any issues in fertility because it is autosomal recessive. One allele was normal, one allele was carrying the deletion. So they had 4 children, one girl who was fertile, she had 4 kids. There was one boy who was carrier like the father, and he had 3 kids, there was no problem. But the brothers, 2 of them, both inherited the deletions from the parents, so it deactivated the CAT-SPR function in the sperm. Both these guys were facing primary infertility, were able to conceive only with ICSI. So this individual went through IVF, and when ICSI was performed, he had 2 kids, and the other individual had 1 son from ICSI. Why is this testing important? The testing is important because patients with this kind of profile, with primary infertility, normozoospermia or actinozoospermia, often get diverted to IUI cycles. If a CAT-SPR deletion is present, your IUI cycles are not going to work, and conventional IVF also is going to result in total fertilization failure or very poor fertilization rate. So therefore, in cases where we face such issues, it is indicated to run the test or directly take up the patient for ICSI. If you do ICSI, there is no problem. There is no inheritance risk if the female partner is not a carrier, and we can, there is no, also the importance is this particular deletion can also cause hearing loss. So it is a clear family history is also important. So these 2 individuals also had partial hearing loss, which correlated to the condition. So just to summarize male infertility, how are the indications versus recommendations? If you have a patient with azoospermia, that is non-obstructive azoospermia or oligozoospermia, you go in for a karyotyping and YCMD test. If you have obstructive azoospermia, you go in for a CFTR mutation analysis. If the male partner is carrier, test his partner. If the partner is normal, proceed with IVF. If the partner is carrier, go with ICSI and PGTA. If you have recurrent pregnancy loss, DNA fragmentation is one of the explanatory tests included in ESHRE guidelines, and karyotyping is also strongly indicated to look for translocations. And if you have male infertility with specific phenotypes like total fertilization failure, poor quality of sperm, bad semen profile, and the patient is consanguous, they want to look at inheritance risk, go for a comprehensive male infertility panel, or you can opt for a couple carrier screening with whole exome sequencing. Am I clear till here? So next I'm going to move to female infertility panel. So when we look at genetic causes of female infertility, we look at the same 3 categories of variants. You have chromosomal causes, subchromosomal causes, and you have mutations. So one of the most common chromosomal causes for female infertility is the Turner syndrome or Mosaic-Turner syndrome, which primarily manifests itself as primary ovarian insufficiency, or they could be skeletal abnormalities, congenital heart defects, physical attributes like a webbed neck, low hairline, flat chest. These are all indications, and as clinicians, we are very well attuned to pick up the possibility of a Turner syndrome. Another variant is also called triple X syndrome. This is when you have 3 X chromosomes. These women are unusually tall, and majority of these women suffer also from POI and genitourinary tract malformations. This also occurs in 1 in 1,000 females. So basically for these women, we offer IVF. The inheritance risk becomes low because usually these chromosomal conditions are corrected during meiosis, but we offer PGTA to screen the embryos to make sure that the children are fine. So when you look at genetic causes for syndromic female infertility, it can be divided into mainly hypogonadotropic hypogonadism, premature ovarian insufficiencies, congenital adrenal hyperplasia, and then you have certain risk conditions associated with recurrent miscarriages and molar pregnancies. Now, polycystic ovarian syndrome has also been coming up to be associated with multiple genes. However, the association with lifestyle and metabolic syndrome is stronger than the genetic predisposition. And even if there is a genetic predisposition, there is nothing we can do about it. So ideally, genetic testing for PCOS is not indicated, but the other phenotypes, we will definitely go in for testing. So if you look at CEH, there is a definite strong link to infertility because it causes hormonal imbalance. This is an autosomal recessive condition and basically associated with a gene called CYP21A2. Here you have excessive androgen levels which can disrupt normal ovarian function, and it can cause chronic anovulation, menstrual irregularities, and which can contribute to infertility. If the male partner is also a carrier, it is possible that it can get inherited to their children. And since these are pathogenic variants, we also use this as part of our newborn screening program, and therefore we can offer interventions in cases identified with this condition. In case the female is found to be a mutation carrier for CYP21A2, you need to test the male partner. Since this is an autosomal recessive condition, if the male partner has no mutations in this entire gene, there is no risk to their babies. All babies will be carriers, so you can proceed without any intervention. So when it comes to hypogonadotropic hypogonadism in females, again, you have multiple genes involved. So Kalamin syndrome, as I said, present in males also, in females also, causes resistance for GnRH hormones. And therefore, investigations can help us understand the inheritance risk to the next generation. Now, when it comes to premature ovarian insufficiency, the first condition that comes to mind is first runner karyotype. The second condition, of course, is Fragile X syndrome. Why is this condition so important? Fragile X is an X-linked condition which basically causes mental retardation in males. It affects only male children. However, females who are carriers can be healthy but suffer from premature ovarian insufficiency. So this is not a condition that can be covered on the karyotyping, and it cannot be detected by whole exome sequencing either. It is a special condition which basically depends upon CGG repeats. So you have normal individuals have CGG repeats around 6 to 50. In the pre-mutation stage, you have 55 to 200. And these are the individuals who will have premature ovarian failure. And when these pass on to the next generation, they have a condition called expansion. So it will get expanded in the next generation, resulting in affected males. So here, when we offer IVF and the patient is insistent on a self cycle, PGTM can be offered for these conditions because the males can suffer from mental retardation and also can have ataxia symptoms. Now, FMR1 pre-mutation is the second test of choice, but it is not the only gene responsible for premature ovarian failure. The second most important gene is called BMP15. This is bone morphogenic factor 15. It is responsible for oocyte maturation, and it is a very valuable input when we because it directly affects follicular genesis. Now, this was a case that was reported by Persani et al. They had found a woman at 23 years having primary amenorrhea who came for fertility treatment, and she was diagnosed with, when they did the mutation test, she was diagnosed to be a carrier for this mutation. So BMP15 is an X-linked mutation, so it's not going to affect males because it's mainly associated with POI. But the challenge is, even in heterozygous state, because of differential X-linked inactivation, it can affect women, causing POI. And because of this, early interventions help us retrieve better oocytes to conceive pregnant, to go for successful conception. So she also had a sister, and follow-up testing revealed that even the sister was a carrier, and even she had primary amenorrhea. So when you look at her, early fertility preservation was possible for the sister, and in case the ovarian reserve is fully depleted, it will be difficult. Now, BMP15 is present at a frequency of 4.5% in POI patients. Apart from this, you have several genes as well. So the ideal range of testing recommended by ASRM is when you have a diagnosed case of POI, you go in and check if there is previous chemotherapy, pelvic radiotherapy, or pelvic ovarian surgery. In case it is not the case, then if there is no such intervention, then you go for genetic testing. So first offer genetic counseling, take informed consent. The first IR testing is chromosomal analysis by karyotyping. Second IR testing is FMR1, pre-mutation testing, and then you can go for additional testing with NGS related panels, which can include the genes that I just discussed. So it is important that in case the patient with POI is unwilling to go for all genetic tests, it's fine, right? And the secondary impact is if they're already ready for a donor egg program, none of these investigations are required except for karyotyping. So if you have structurally normal uterus and the patient is ready for donor egg program, we need not run the other genetic tests. So this was a case where we got this BMP15. This was a non-consanguineous couple. Both first IVF cycles 1 and 2 got cancelled in view of no oocytes received. There were no mature oocytes that were received. And the male partner had severe oligoasteroteratospermia. So there were occasional sperm seen. They were ready for ICSI. So they went in for carrier screening panel. And we found a likely pathogenic BMP15 in the female partner. So this was responsible for premature ovarian failure. Based on this result, we were able to counsel her saying that there is probably ovarian dysfunction. So it is time to go in for a donor egg program instead of repeating the second IVF cycle. So the key feature of genetic conditions is they're very consistent. They usually repeat themselves. So when you see the same kind of phenotype in 2 consistent IVF cycles, it's very beneficial if the patient is still coming back to the same clinician, because when they move and change doctors, we kind of lose track. But in such cases where we consistently see there are no oocytes received and the retrieved and the stimulation protocol was good, it is ideally preferable to go for the genetic testing to evaluate if they have such kind of predisposing factors. So this is the workflow for genetic testing for female infertility. If you have a normal phenotype and you go for ART and you face oocyte maturation defects, premature embryonic lethality, or recurrent miscarriage, you go for a karyotyping. If the karyotyping is abnormal, it's fine. You act based on the abnormality. Usually if it's a translocation or a mosaic Turner syndrome, you act accordingly. But if it is normal, you go in for a genetic screening panel. In case there is abnormal phenotype, depending on if it is recurrent miscarriages, differences in sexual development, hydatiform moles, or hypogonadotrophic hypogonadism, first run the karyotype. So we can see here karyotyping is never skipped in the entire workflow. Then based, if it's CH, go for CYP21A2 mutation. This has 2-tier testing, mutation and deletion duplication testing. If it's POI, you go for FMR1 mutation testing. If they are normal, then you go in for the in silico panel. So specifically karyotype followed by targeted testing for condition which we are looking at, then go in for the NGS panel. So this was still female infertility. So what about genetic causes of IVF failure? So when we face IVF failure, we have to define at what stage of IVF are we facing the failure. We have to evaluate the sperm quality, the oocyte quality, the stimulation protocol, the embryonic development, or is it failed implantation? So where is the challenge coming from? The next step, of course, is to rule out the lab factors. We need to make sure the media batch is okay and all QA/QC parameters of the lab are stable. Other cases performed at the same time are running frequently. So this is when they come to me. I am the last person you should come to when there is IVF failure. So first find out all these factors, because without these information, we geneticists are blindsided. We will not be able to help you. So once we know exactly at what stage of IVF are you facing failure, then we will be able to act on it. So one suggestion I strongly recommend that while ordering these genetic tests, never give the indication as IVF failure. So IVF failure is known to IVF specialists at what stage it is, but the genetics lab is completely unknown. So based on what stage of IVF failure you define on the report, then we will be able to run the analysis. Was it IUI failure? How many cycles of IUI failed? How many oocytes were retrieved? Was it a maturation defect? Was it a stimulation issue? Was it embryonic arrest? Was it implantation failure or poor embryo quality? All these are phenotypes that are important while we offer genetic testing. And you'll understand shortly why. So if you look at, again, IVF failure, the primary culprit is the aneuploidies. So aneuploidies can either come from the egg or the sperm. They can come from the embryos as such during development. And mainly these aneuploidies will cause implantation failure. It can cause miscarriages. And that is reported. Up to 50 to 60% of first trimester losses are because of chromosomal conditions. And then you have fetal anomalies. Now, all these factors which can be caused by aneuploidy can be listed only if it's miscarriage, test a miscarriage tissue, we will know it is chromosomal, then we can act accordingly. If it is fetal anomaly, test the fetus with the microarray, find out the chromosomal cause, do a follow-up testing for the parent, then find out what to do. But for all these problems, the primary solution is pre-implantation genetic testing for aneuploidies, where we go through IVF, we generate embryos, and we test them for chromosomal number variations, and we use a chromosome normal embryo for transfer. But what about other factors? Now, we have multiple stages of embryonic development governed by multiple genes. So if you have only GV oocytes retrieved, there is a gene PANX1 which is associated with oocyte death. If you have GV arrest, there is P80L2. M2 maturation arrest, that M1 maturation arrest, that means all the oocytes we are receiving are M1 in stage and have not matured to M2 state, then you have TUB8 and TRIP13 mutations implicated. You also have zona abnormalities ZP1, ZP2, ZP3. They're also associated with zona-free embryos, oocytes, sorry. You have genes associated with fertilization failure. You have also genes associated with zygotic cleavage failure. And most important are the early embryonic development arrest genes. So when you face embryonic arrest, as I said, first evaluate the quality of the oocyte. Now this oocyte looks just fine to me. And when there is no structural defects in the oocyte or the sperm, we have used good quality oocytes, good quality sperm. Karyotyping is normal for the couple. And DNA fragmentation index also is in the good range only. So definitely then we suspect genetic conditions. So that is when we order these male and female factor infertility tests. So a few examples of these are mainly genes associated with fertilization failure and rescue. So a certain list of genes are associated with potential markers of total fertilization failure. So when you have very poor, unanticipated, very poor fertilization or total fertilization failure with good quality oocytes, then you need to look at lab factors. And if lab factors are stable, then definitely there should be a look at the genetic factors. So why is it important to evaluate this? So the first idea when we have total fertilization failure is do a rescue with artificial oocyte activation. Now the importance of genetic testing is if the mutation causing fertilization failure is present in the sperm, artificial oocyte activation will greatly improve the outcome. So here we can see sperm related mutations. If it is PLC theta 1, you have fertilization both in conventional IVF and ICSI to be ranging from 0 to 66%. But if you include artificial oocyte activation, you can reach 100%. Same is the case with the ACTL9, you can reach up to 100% success rate. Whereas if you do ICSI, it is 16%. So here you can see somebody with this gene mutation is not a candidate for conventional IVF. They are going to face total fertilization failure. With ICSI, we're going to face only up to 16%. But with ICSI plus artificial oocyte activation, we are able to receive 100% fertilization. Now, but if the variant is oocyte driven, you can see here the oocyte driven mutations are TUB8, NLRP5, TLE6, and ZP2. There is no success even if you employ artificial oocyte activation. And here, if it is ZP2, definitely ICSI is the only way. But if it is other mutations, you will fail even if there is artificial oocyte activation. And in such cases, donor egg programs are what is recommended. So you can use these genetic testing also to help the patient understand why are we going for donor oocyte programs. So this was a very interesting case we had. In fact, I have 4 such cases like this seen in the past 8 to 9 years. So this was a non-consanguineous endogamous couple. They belong to the same caste. There was no significant family history while looking at the general overall view. So there were people who were pregnant and continued to have healthy pregnancies. But this woman consistently had 3 pregnancies, ended up in high datiform mole. So usually molar pregnancies help us think, okay, this is a chromosomal cause, the recurrence risk is low, the chances of this happening are very few. But when it happens again and again, so it's a characteristic feature of a genetic condition, a recurrent phenotype. So all 3 pregnancies had the same phenotype, all 3 high datiform molar pregnancies. When we we went in for genetic testing, and when we do genetic counseling first, we take a detailed 3-generation family history. So when we deduct that history, the lady over here, her maternal aunt, so mother sister basically, had also had a similar problem, a high datiform molar pregnancies. 2 IVF cycles were already done at a center elsewhere with poor oocyte quality, all embryos arrested by day 3. When we did the genetic testing, we were able to find that she and her husband are both carriers of this mutation on a gene called LNRP7. It is an autosomal recessive condition, but she had a homozygous mutation. That means all her genes have a homozygous non-functional LNRP7. Now, this gene is very important for oocyte developmental potential. So all her oocytes were extremely defective. Her mother was able to make oocytes because probably the mother was a carrier and her father was a carrier. So in carrier status, they are able to make good eggs. But because of the homozygous mutation, her oogenesis is failing. So there was no way that another IVF cycle would help her. So instead of spending another 2-3 lakhs in another IVF cycle, they were counseled clearly for the genetic testing. Based on the findings, we went in for a donor egg program with a cell sperm. And here, if they choose to, they can choose to screen the donor as well. And we can see that in patients with recurrent high datiform mole, 50 to 80% of these patients pick up genetic variants on LNRP7 and KHC3L. And these mutations always impact the oocyte developmental competence. Another patient that I had consulted me with the same condition. They were told by some geneticists that they can never sustain a pregnancy of their own. So it is important to understand how the gene functions. Here it only impacts oocyte development and does not impact her ability to carry the pregnancy. So with the donor egg program, she was able to conceive and have a healthy pregnancy. Another concept we face is called OZEMA, oocyte zygote embryo maturation arrest. So what happens is when we have consistent cycles with embryo developmental arrest, usually we first doubt on the embryologist, is everything in the lab proper? So once the embryologist has been thoroughly grilled that everything is fine, we have done everything perfectly, the lab conditions are optimal, everything else is working fine, you need to suspect that there could be a genetic cause. And this can help understand many cases of IVF failure. Here, when there is embryonic arrest, there are at least 10 genes listed associated with this. So it was first reported in 2020 by Zheng et al. Here they had 4 unrelated Chinese women, 3 from consanguous families with infertility, all had a mutation on this gene BTG4. And they had normal menstrual cycles, normal sex hormone levels, and all of them had 2 to 3 failed in vitro cycles. And in all instances, they retrieved multiple oocytes. They were successfully fertilized, but either there is cleavage arrest or failure to cleave. So in such cases, this kind of findings help us define what is the actual case. So we also had a case of a very young woman, 28 years old, with 3 IUI failures. So this is how when we get detailed history, we can give informative results. Okay, so they had 3 IUI failures, 3 IVF cycles done, and all 3 IVF cycles failed because first cycle got only 1 M2 oocyte, second cycle got 14 M2, only 1 day6 embryo was formed, and third cycle had 13 M2, no blastocyst formed. So the clinician directly ordered a whole exome sequencing. We were given basic findings saying that there was IVF failure. So the whole exome sequencing was done. We didn't find any significant findings with these particular variations. So when we went for post-test counseling, I suggested to undergo what we call the female infertility panel. Now, the difference between the whole exome and the female infertility panel is the whole exome looks as only mutations. If you remember from my first slide, mutations are under what we call American College of Medical Genetics reporting guidelines, where we report only disease-causing conditions. But the female infertility panel looks at polymorphisms. These are population-specific variants that can actually cause certain manifestations, and they become significant based on that. So This particular patient, when we analyzed the female infertility panel, we found a mutation on TUB8. So TUB8 was in homozygous state in this woman. So when we went for the post-test counseling, we got the entire details transferred to our bioinformatics team. And when they did the analysis, now we have a reason. It is uncertain significance, but there is definite correlation to what she's finding. So we went back, looked literature, and there were several papers that have shown that in normal individuals, you get very good quality oocytes which progress to blastocysts. This was a representative image of two families with TUB8 mutations, homozygous, where they had poor quality oocytes, large polar bodies, and they fail to cleave. You get only two cell stage and then you get fragmented embryos with day 3 arrest. And with this information, we were able to help her understand why her 3 cycles have failed and why she needs to go for a donor egg program. So you can note here that her AMH is 5.7. So there is no issues with the AMH level. So ovarian reserve is not getting impacted. Another factor is, of course, polymorphisms that present on LHCGR and FSHR genes, which have a differential response to ovarian stimulation cycles. I'm not going to stress much about this because if you have seen previous talks by Dr. Ramaraju, he is extensively discussed about this. And these are two tests which we offer when there is a failed response to an ovarian stimulation cycle. And based on the variants detected, we will be able to titrate the stimulation protocol to help the patient achieve mature oocytes. So to give you an overview, the key indications for testing and the test offered. If the patient is coming to you with recurrent pregnancy loss, don't go about ordering all these panels. The first test to do is karyotyping. Then test the miscarried tissue, find out if it is genetic or not. Then if it is normal, then you need not evaluate genetic causes. You need to look at autoimmune factors. Then, in case it is genetic, we have an abnormality on the karyotype, we go for IVF with PGT-A or PGT-SR, depending on the anomaly. If it is primary ovarian insufficiency, we first do karyotyping, then we do the FMR gene repeat expansion testing, followed by mutation panels. In case you have a family history of known conditions and specific phenotypes, you can directly go in for a specific female infertility panel. Here, you need to provide clear phenotypes. If there is consanguinity, you go for carrier screening. But in no condition which we have tested, if you offer whole exome sequencing to the couple in conditions of IVF failure and in conditions of recurrent pregnancy loss, we very hardly find variants. If it is recurrent pregnancy loss because of high datiform mode, then we find variants. So when you give RPR also, you need to give us a subcategory of how many pregnancies have been lost, what was the finding for each pregnancy, and based on that, we will be able to decide what test to do. If it is poor ovarian response, go for LHFSH receptor polymorphism alone. You can go for a targeted testing itself. So genetic counseling is important part of this reproductive journey, especially when genetic tests are involved. So as clinicians are extremely busy, there are a lot of patients to see, they get minimum time with each patient. So it is not possible to take a detailed 3-generation family history, get all the details from previous IVF cycles. But if you push through genetic counseling, the genetic counselors are tasked with recording these phenotypes. And when these phenotypes come through the genetic counseling, the genetic testing for us becomes easier, the bioinformatic analysis is more informative, and the output of the test drastically improves. And it also helps the patient understand what is the difference between all these tests. Otherwise, they keep thinking doctors are ordering test after test after test and we're fed up. So it's important to explain why the test is done. So offer a pre-test genetic counseling, then do the test, then offer a post-test counseling to explain the results, and based on that, we can take up clinical actions. So when it comes to clinical actions, it is important for us to give phenotype. And this is just one case that I wanted to share with you, which highlights the importance of phenotype. So this couple had recurrent IVF failures. They came to us with this history, 3 early missed abortions due to absent cardiac activity, low AMH, did not define what was the AMH levels, couple karyotyping was normal, and it was non-consanguineous couple because of which whole exome sequencing was ordered. We did the test, we found conditions which are not associated with any of the phenotype that they have given. So the whole exome sequencing was non-informative for this couple. Then we went back, did the post-test counseling, and we took a detailed family history. We found that this was a case of secondary infertility. They have a child who is healthy and well. IVF cycles, 2 cycles were done. 2 eggs were retrieved in the first cycle. Both were GV. They did IVM, and they got only 1 mature egg, which was fertilized, but day 3 arrest. No embryo development beyond day 3. IVF cycle 2, 4 eggs retrieved. 1 was GV, 1 was M1. 2 were M2. So the M1 was put and the GV were put into IVM. M2 was fertilized on day 1. Second day, one of these oocytes matured, so second day XC was done. But again, you faced embryonic arrest. The AMH levels was 0.36 and AFC also was very low. So these are the details the embryologist actually helped us with on getting additional AMH values and AFC levels. And then when we did the female infertility panel, we found that there is a homozygous polymorphism on AMH, which is associated with progressive decline in the ovarian reserve, which is faster than the general population because she is just 35 years old right now. The AMH is also low. She also had additional polymorphisms on MTRR and MTFHR, both which are part of the MTFHR pathway, and this can cause accumulation of homocysteine. So then we looked at the level of homocysteine; it was slightly elevated, and we know that MTR and MTFHR both cause predisposition to this. So based on this, the next pregnancy was. Obviously, they will go for donor egg. The case is yet to happen. So the post-test counseling involved both options. The patient will think and decide if they want to go for a donor egg program or. So irrespective of their choice, if they choose a donor egg program, we need to give them medications, additional folic acid supplementations, and also to reduce the risk of NTDs as well as impaired trophoblastic invasion. They have a risk of placental vascular thrombosis. So low molecular weight heparin also can help in such cases. So it is just to emphasize the importance of phenotype. So if you give us very basic phenotype, the analysis also happens the same way. And then if you give a refined phenotype, the analysis improves. So this is very important while offering these kind of tests. So to conclude, advanced genetic panels are phenotype specific. They have been reported to have a diagnostic rate of 11 to 20% in males and females both. On an average, the study that I referred to had 11 to 13% reported already. And these genetic panels keep evolving. So the more phenotype you give, the strong is the evaluation. And based on these panels, they can serve as excellent clinical decision-making tools to offer the right kind of reproductive outcomes for patients. So just to stress again, while ordering genetic panels, the phenotype is extremely important. Thank you.
Thank you so much, Fiona. I think you should take a voice rest, but I have a lot of
please drink
questions
some
and I have
water.
taken a lot of notes from you, and I have a few questions to ask you, and also there is some questions on the chat box. So if you want to just take a 1 minute break, you can take a 1 minute
No,
break.
I'm
And
fine.
it's so amazing that she's so thorough with the subject that she did not even think for 1 second.
Yeah,
for
yeah,
what
it
she
is
was
just
speaking.
years
It
of
was really
experience
nice.
and the commitment to this subject. You know, her passion to the subject is very much visible. Thanks, Fiona.
Thank you.
Thank you so much. So, can we start?
I
with the
launched the
questions?
quiz, ma'am, simultaneously, and we'll take the
Sure.
questions. So participants
Sure.
can
Sure.
attempt the questions. So I encourage you all to participate in the quiz. It's anonymous, just to make sure how much you have understood. Shall I ask the questions in the chat box first?
Can I start first? Because
Yes,
I
ma'am,
just,
yes, ma'am.
yeah. So, Fiona, from the basics, from where you started, just to have some summary, like karyotyping indications in male infertility, the basic thing that we really order. Sometimes we have to go by severe male factor, or, as you mentioned, phenotype is extremely, extremely important. So just a few points on when we should do karyotype testing in male infertility.
So basically, karyotyping is indicated in any kind of dysmorphic features. If you're anticipating Klinefelter syndrome or any kind of hyperactivity exhibited by the patient, and also in cases of azoospermia.
Okay.
Azoospermia, oligospermia, these categories we will be offering karyotyping first.
Okay. So obviously clinicians would want to do it in, recurrent pregnancy loss and, recurrent IVF
yes.
failures and all those things. So
Yeah.
The other thing is you were talking about DFI and, and you were giving us cutoffs. I'm sure that the cutoffs of 15% and above is only for, your tunnel or SCSA assay as compared to the SCD, which is like, there's having some subjective variations and based on halos and other things. In this background, you were mentioning that, there could be mutations whenever there is raised DFI samples. So is there any evidence to say that, we should be doing PGT testing in men who are having raised DFI? Of course, we are going to do lifestyle interventions. We are going to try to modify those causes which has caused the raised DFI. However, should we kind of look into PGT testing in men who are having, raised DFI going for IVF ICSI?
No, ma'am. So for raised DFI, you need to do only DFI testing. There are no genetic variants that predispose you to DFI. So the only cases where you have genetic predisposition to elevated DFI is what we call a histone protamine ratio change. So when you have increased number of histones, the packaging of the sperm gets altered. So definitely you will have teratospermia. And those cases, any which we are predisposed to high DNA fragmentation. So you need not do genetic sequencing for high DFI cases. However, if you have abnormal semen profile, including asthenospermia, teratospermia, oligoasthenospermia, and complete immotile syndrome, then you need to do the karyotyping followed by the NGS panels.
And
For DFI,
probably the raised DFI is associated with previous RPL or,
yes, yes.
RAF, then in those
Lifestyle.
cases, probably we are going to add on this PGTA, correct?
Yes, yes. So
we-
what is important to understand is PGTA cannot look at DFI. So in certain cases, it is reported, very few reports are there that associate increased DFI to increased probability of aneuploidy. Because there was one recent report that showed that double strand breaks on the sperm can trigger mental aneuploidies in embryos. If that aneuploidy is within the coverage of PGTA, you can offer PGTA. But strong evidence to offer PGTA for male factor. So in the indications of PGTA, male factor has the least evidence. The advanced maternal age, RIF, RPL has higher indication strength. It is debatable. It depends on the conditions and situations you can see. But we have to explain to the patient that PGTA cannot look at DNA fragmentation. So in cases of DNA fragmentation, a PGTA euploid embryo which is carrying DNA fragmentation can fail to implant despite good morphology. So in the study that we did, we were actually working on a mouse model. Then we were inducing DNA fragmentation in sperm and doing in vitro fertilization and running embryonic development. And we did an apoptosis assay in the blastocyst. So what we found was there was no impact on fertilization rate, but reduced embryonic development, increased arrest at the morula stage, and increased apoptosis in morphologically normal blastocyst. So this is an impact which none of the genetic tests are available for human embryos to evaluate apoptosis. PGTA cannot see it. So here you have a limitation, and this is one of the points we do use to counsel patients when PGTA euploid embryo fails and we have high DFI patient as well.
Okay. There's a question in the chat box. Along with that, I'm just going to continue. The chat box question is, when do you do, Y chromosome microdeletion testing, which you mentioned in azoospermia patients and also severe male factor. In this vein, we also see the report, showing AZF A, B, and C. You also mentioned that AZF D is a segment which is reported. It is only showing small distal deletions. So is this present in the report? Because I'm not really remembering whether we can see this AZF-D. Is that reported in all the reports?
No, the frequency is low and most of the focus is on deletions on AZF, A, B, and C. It is reported in literature, but in the commercial test, AZF, A, B, and C is included.
A, B, and C. So that's fine. So, when you were talking and you were saying that, the couple insisted that, if they're having deletions and then it's going to be, transmitted into a male child, definitely. So just to eliminate that, because of the PCP-NDT, we are not allowed to, select a female child. But I had 2 instances where the couple really, insisted, and how practical it is to, because they say that it's severe male factor, we don't want our, children or to be affected and things like that. So it was quite a difficult decision. So is there a platform where they can go and, appeal for it and get, have you had experiences like that?
No, ma'am. Until now, even I have had several patients who were asking us for the same thing, because we factor in phenotype-driven manifestations, but we are not factoring the psychological trauma the male is going through because of said infertility, and it is going to impact his son. And we have had many patients who say that I don't want my son to go through what I'm going through. But the difficulty is there is a provision under PCP-NDT to offer gender selection for sex-linked conditions. But because of the possibility of misuse, most of the genetic laboratories are very careful while getting into this. And that is why you can explore other genetics lab, but usually if from Anderson's point of view, I can tell you our protocol is to help them get in touch with the lawyer and approach the court and get a decree, because the lawyer's word does not hold good for the company, but the court's decree is absolute. So it's in support of the law. So if we have that, then we are allowed to do the intervention.
Okay. So you
So
were
the legal
mentioning that.
documentation is careful. Better to discuss with the lawyer and take a call on that.
Okay. So you were discussing about CBAVD and CFTR gene testing, right? So if the male partner is negative, then we have to do that testing of some, very complex thing, ADGR, X-linked recessive
ADGR2,
testing.
yes. Not mandatory, it's an X-linked condition. So the difference, CFTR is an autosomal recessive condition. So if your female partner is a carrier, there is a risk for the child. But
No,
the
but
male
if the
partner
male
is
partner is
X-linked,
negative, do we still
all
have to
his
test
children are
this?
going, only female babies are going to be carriers. It does not impact the female babies, and the male babies are going to be fine. Because he's not going to give the X chromosome to the male children. So we need not plan for additional testing. You can directly proceed with the TISA and ICSI.
Okay. So you were mentioning about some genetic panels in azoospermia. So just from the clinician's perspective, how do we write that? What panels and what genes are tested in male infertility panel for
Every panel
azoospermia?
has their own. Every company has their own genetics panel for male and female infertility, because it is indigenously developed, and it's not like a single few set of genes only for azoospermia. It's a single male infertility panel which includes all the phenotypes, because that's how it becomes feasible to run the test. So when we order the panel, you can order male infertility genetic panel, and you can list the phenotype that you're seeing. You're having asthenospermia or teratospermia or immotile syndrome, complete asthenospermia, include the count motility, attach the semen analysis report, and these are phenotypes that can help us diagnose what we're looking for.
Okay. Let's give
It
you
can
a voice
also be
break.
offered in cases of fertilization failure as well. Same
Okay.
male. In fertilization failure, you need to order both male and female infertility panel. So once it comes to post-fertilization events, both the panels need to be ordered. So if you're looking only female specific phenotype like POI, you order the female infertility panel alone. Or you're looking at only male specific phenotype like hypogonadotrophic hypogonadism or semen profile, you order only the male. But once the fertilization happens, fertilization onwards defects, you order both panels.
So you were mentioning about severe asthenospermia or poor motility. If there are no other features like, of carcinogenous syndrome, everything else looks normal. What test do you recommend, whether we have to do for that MMAF testing, if wife is not a carrier, then what kind of testing do you really recommend in these poor motile samples actually?
So in poor motile samples, if you are able to get motility, then we can go ahead with fertilization, ma'am. Because if this is affecting this generation and it's going to go to the next generation also, they can still go through IVF, and we don't know what advances will happen in the next 20 years. So if you know, recently we are now for the first time there's a possibility of generating oocytes from skin cells. So we have reached there already. So there's no saying how much we'll be able to achieve in the next 20 years. So possibly they will have more options than we have now when their children plan to conceive. So in those cases, I don't think genetic testing is strongly indicated.
And you were mentioning like, normozoospermia and then CAT-SPR testing. So in normozoospermic sample, when do you really go for this testing, Fiona? It's very, complex for me to understand.
Yes. So there are two schools of thoughts here. So if you are a center who offers 99% ICSI, you need not worry about CAT-SPR. Your patients can directly go for ICSI. So ICSI going patients don't require CAT-SPR gene testing. CAT-SPR gene testing is indicated for patients who have undergone IUI and have failed despite normal semen profile, and you have no female factor involved. And all the IUIs are failing, and your patient is still not ready to move to ICSI. So this is the time to run the test to say, look, now you need ICSI because this is the challenge you're facing with. Also look at additional phenotype. Is the male also having any kind of hearing deficit? So that is one more key feature of the CAT-SPR mutation, especially on CAT-SPR2. There are other CAT-SPRs, but they're very mild, so they don't really impact that strongly. This actually, we don't know the frequency of CAT-SPR mutations. So in the reported study, Dr. Samuel Young has reported the frequency of 1 to 3%. So it's mainly for patients who have failed IUI cycle.
So sometimes, failed IUI cycles, we go for, sperm parameters are normal, everything is normal, and then we go for a conventional IVF. Sometimes we landed in poor outcomes. Could be because of this factor, and then we have to resort to ICSI. So, but then again, it's a debate that, whether we should do ICSI for all normal samples, failed IUI is another debate to discuss.
The reason I included that slide is because now we have been doing ICSI as the primary tool for fertilization from many years. And now there is a wave of going back to what we were doing earlier to bring in the natural selection process. And many people are going back to conventional IVF. So when we do go for conventional IVF, and in case even a single cycle of conventional IVF has failed, we rather not repeat it. So either do the test, or in case go through the risk of conventional IVF. If it fails, don't repeat like conventional IVF. You definitely should be shifting to ICSI. Because now the challenge is, ma'am, patients read on ChatGPT and they dictate to us that they don't want ICSI and they want IVF. And that is a difficult. That is when these evidences are going to help us.
Correct. So you were mentioning about this Fragile X testing and FMR1 testing in POI. Definitely, if they are going, we have identified the patient with POI. So if there is no possibility of self gametes, donor gametes, this testing is not required. So where this has a place, like fertility preservation, again it's a question mark, right? So is it for counseling purposes, or what it is, like, how frequently are we able to offer self gametes in POI patients, where it really fits in this testing?
So what is important is the patient who is eligible for an FMR1 testing is somebody with POI who is insisting on a self cycle. And usually with POI, you already have limited oocytes that are expected. And our success rate is also going to be poor. So you are looking at pooling cycles. We will be running 2 or 3 cycles. So we did have a patient who was from Bangalore who was very insistent on a self cycle. Her father already has some level of ataxia that is shown. But in these FMR1 gene, it acts a little tricky. So sometimes it reverts back to the pre-mutation state in women, and then goes into the mutation state when it comes to the next generation males. Or in the previous generation also, if it's a male, she got the variant from her father who had some mild symptoms. So she was very insistent on a self cycle. We did the FMR testing, and karyotyping was normal. We did the FMR testing. She was a pre-mutation carrier, and there was a risk for her sons. Therefore, we opted for PGTM, which is allowed under TCP/NBT. And we tested because in the X-linked category, she could have 25% female children normal, 25% male children who were normal, 25% female children who will be carriers, and another 25% males who will be affected. So there is only a 25% possibility for the children to be affected, but she deserves to know. So when we run the test, we can tell them these are the affected embryos, let's not use them. The remaining embryos, which are fine, going to be okay, we can use them for transfer. So completely mutation-free embryos can be selected for the transfer. She underwent 3 cycles of IVF for us to have enough embryos for testing. And FMR1 testing is usually done in an indirect way. We cannot do it in a direct testing modality. And she was able to conceive after that.
That's excellent. Can I now request Sindhuja to please end the poll and share the answers, and also take the questions on the chat box, please?
Sure, ma'am. Mending the poll. So the first question was, expanded carrier screening in reproductive medicine is recommended primarily to, majority have answered it correctly, that it's identify carriers of common and severe recessive or X-linked conditions before conception. Which of the following chromosomal abnormalities is most likely to result in non-obstructive azoospermia? Majority have answered correctly, that it's Klinefelter's 47XXY. Carrier screening for hemoglobinopathies such as thalassemia is most effectively performed by, majority have answered it correctly, hemoglobin electrophoresis or HPLC. Which of the following disorders is not typically included in the expanded carrier screening panel? 55% have answered correctly, that it is hypertension. And PGT for monogenic diseases primarily detects single gene mutations. That has also been answered correctly. So I think everybody's been paying great attention. And I think questions in the chat box, I think Vasundara ma'am has asked some. I think Samru Shankari ma'am has asked, what is the incidence of FMR gene in FMR1 gene in POI? I think you just answered that question. And madam has asked, have they responded to regular methods of increasing the ovarian reserve? So I think ma'am's trying to ask by like PRP, or I think that is what ma'am is trying to.
I don't think so. The ovarian reserve cannot be improved in FMR1 cases because you have a genetic predisposition to poor ovarian reserve. So possibly the recruitment of existing follicles can be improved, but you cannot improve the reserve at all.
Okay. So another participant has expressed his delight to attend the masterclass, and many have congratulated you on your exceptional presentation. And there are three questions from him, but I think to generalize it, he's asked, how do we bridge the gap between genomic insights and clinical decision making? I think you've extended many points on that one. What frameworks are needed to interpret genetic data meaningfully and ethically? I think a reliable geneticist and a genetic counselor is required for this purpose. And how close are we to AI-driven genomics transforming IVF practice is his question. Do you have any?
So we are already in development of AI-driven tools, which will help fasten the analytical protocol. But however efficient our AI-driven tools are, the AI cannot deliver phenotypes. So the phenotypes are still in the hands of the clinicians to clearly and explicitly describe them. So even in that, without an AI tool, our existing 6 to 7 databases will be able to give us good information. AI tools are going to fasten the process. They are going to make it easier for us to report to you faster. Now we take 3 weeks for reporting, then maybe we wouldn't take that long.
Yeah.
We'll be fine.
So I think
I think, Fiona, I just have a question. You were mentioning about testing for oocyte maturation and the genes. So we have had,
Yes.
few patients who, despite giving best of protocols, testing, doing dual triggers, still we land up with, maturation problems. So, or they, sometimes we have a lot of oocytes. We have had patients with PCO, beautiful embryos on day 3, and then, all of them arrest on day 5. So probably, should we do this panel, which you mentioned, the maturation arrest gene panel? And if we do it, it is only for counseling purposes and to make them understand why it happened, and for, making them more comfortable about donor oocyte program.
Yes, ma'am. So there are 2 categories of patients, as you already know more better than me. You deal with more patients than I do. But in case the patient has already made up their mind, they understand what you're delivering to them is scientific, everything is done correctly in the lab, and it is time to move for a donor egg program. If they're ready for that, they do not need to do this testing. But some of the patients are always in denial and they're not able to understand it, and they end up going through cycle to cycle facing the same issue. And a genetic testing gives a very clear answer, like this is the challenge you're facing. So maybe we can stop here now and then look for things. So as a counseling tool is a primary purpose of this kind of investigation. It's not like we can do any different interventions to improve the situation. So the challenge with genetic variants is they cannot be corrected, they cannot be repaired, they cannot be treated. So for such reason, these tools are very important.
So when do we do anti-ovarian antibodies? In one of your slides I saw, and it's quite, I think it is done by ELISA or Western blot. I don't know the methodology, how you test. And is it really recommended? And when should we do anti-ovarian antibody testing?
I don't think it's a mainstream test. It was part of a paper that was published. So as part of the research study, I think they have done it to substantiate the impact of BMP15 mutation. So when you report a new mutation, we are implicated to look at both the impact on the phenotype, the protein-related changes, and they have to be provided with certain evidence. So if you're getting a new mutation and you're providing evidence for this, these kind of antibody testings are done in the research context. I don't think there is a role of these in routine clinical practice.
Okay. And, sometimes, I've heard something called as sperm aneuploidy testing. What do they test in sperm aneuploidy? And, ultimately, there's some percentage, some figures, and, these people would be better off with PGTA cycle. What do they actually do in sperm aneuploidy testing?
So I am a strong disbeliever in sperm aneuploidy testing, because I believe in the end, we are not able to see normal euploid sperm, haploid sperm, and abnormal sperm. So it is absolutely left to chance. And given that the acceptance for PGTA is higher, that is a more informative test than wasting money on sperm aneuploidy testing. Also, what's important is the sperm has 23 chromosomes it is carrying, and sperm aneuploidy testing is done by FISH method, and which is a cytogenetics technique, and it's mainly done for 5 chromosomes, 13, 18, 21, XY. So anybody who does IVF and does PGTA knows that the highest percentage of chromosome aneuploidies are seen in other chromosomes also. Now, in routine clinical practice, when we look at clinical pregnancy, the increase incidence of 1381XY is present. But in IVF gametes, we have aneuploidies on all chromosomes. Especially, we have seen a high frequency of aneuploidies on chromosome 16, 22, 18, 15, etc. Now, because this information is not delivered, I think this is an insufficient and unscientific test, and it is not clinically relevant test. Some people have come to me saying that it can convince the patient to go for PGTA. PGTA is much stronger indication than sperm aneuploidy. I have searched through literature to find a cutoff for sperm aneuploidy. It does not exist. Certain people say you need to do lab-developed sperm aneuploidy cutoffs. There was one small research in Cornell University which was reported saying that even a two-fold increase in sperm aneuploidy rate can increase the embryonic aneuploidy rate by 30%. So even a 2% aneuploidy is high enough. But we did a study when I was doing my PhD. My colleague did a study basically on radiation health workers and the incidence of sex chromosome and other aneuploidies in sperm. It was a very extensive study. And even there, in the predisposed exposed category also, we found very few, small frequency only, hardly 2% to 3%, if I'm not mistaken. I can share the paper. It's published in PLOS One. Dr. Dayanidhi Kumar Sharma is the one who did that study. So what we find is there are sex chromosome aneuploidy. So you're better off offering PGTA for it because we need to factor in the female factor also while looking at aneuploidy. So I don't recommend sperm aneuploidy testing to
Wonderful,
anybody.
because somebody, usually as clinicians, we should also be having this knowledge, because ultimately I asked one question, end of the day, when you have made up your mind that, there is an indication for sperm aneuploidy testing, that means there is a definite indication for PGTA testing. So why not
Yes.
go for a more robust NGS platform and then do the entire PGTA testing rather than, spend money in SAT and then, having a poorer outcome. I totally agree, and thanks for that insight, Fiona.
I think it's the same reason we don't offer polar body biopsy. Because polar body biopsy is only giving us maternal meiotic errors. We are not factoring for mitotic errors. We are not factoring for paternal aneuploidy. The same way sperm aneuploidy is also redundant. We should be offering blastocyst stroke ectoderm biopsy for chromosome screening if you want to avoid chromosomal risk.
Thank you so much, Fiona. Sindhu, is there any other question on the chat box? I think we had an exhaustive session. We really benefited. I have taken lots of notes from your lecture. I think more and more, it's a very volatile subject, but still you have made it so interesting and so nice by putting in real case scenarios. It was extremely, extremely informative, and that is what all our delegates have also, expressed. We extend a wholehearted thank you and a huge gratitude for accepting and doing this exhaustive part 1 and part 2 sessions, Fiona. Thank you so
My
much
pleasure.
for all the delegates for being a part of this masterclass and masterclass. When is the next masterclass, Sindhu?
Next week, next Thursday, ma'am, October 16th.
Okay, so we will
Dr.
soon
Sachin Kanal.
meeting with the next. Yeah. Thank you so much, everyone. Thanks, Sindhuja.
Thank you, ma'am. Thank you, Fiona.
Thank you, Fiona. Bye.
Thank you so much, ma'am. Thank you so much.